Good morning, ladies and gentlemen. My name is Emmanuel Ledoux. I work in the Department of Internal Medicine and Clinical Immunology in the University Hospital Center of Lille in France. I'm pleased to share with you the latest knowledge on the pathogenesis and management of malignant atrophic papulosis. This presentation complements Professor Ott's on clinical aspects. So before we turn to the pathogenesis of Degos disease, I would like to share a few slides to provide some context. So first, what does malignant atrophic papulosis look like? So this is the story of a man in his 30s without past medical history. Please note that 35, 37 is exactly the median age at which the first Degos disease sign appear. So he noticed the occurrence of 20, 50, 100 very stereotyped skin lesion, and leading to the diagnosis of a benign atrophic papulosis confirmed by histological findings. 18 months after disease onset, he was complaining of impairment of the vision, explained by retinal ischemia, and you can see the ocular fundus examination on the right-hand side of the slide. And look at the top, there is also an area of conjunctival ischemia. And at the same time, he was complaining of ptosis and diplopia, and that was explained by an infiltration of the retroorbital fat and oculomotor muscles. The brain MRI also showed punctiform strokes and leptomeningitis. At the same time, he was complaining of abdominal pain and loss of weight, leading to a coloscopy, and multiple millimetric ulcerations were found. And unfortunately, a few months later, he was admitted to the emergency department for a peritonitis due to multiple intestinal microperforations. The etiological workup found no evidence of overlapping with autoimmune disease, no infectious trigger, and please note the very high level of the blood interferon gene signature, more than 100, so that is much higher than is usually observed in lupus systemic. So if we were to meet him at the time of the peritonitis, how should we treat him? So before to answer to this question, we have to come back on what we know about pathogenesis of malignant atrophic papulosis. So when we look at the skin, the brain, the heart, the gastrointestinal tracts, we observe that early lesions exhibit significant angiocentric lymphocytic infiltrate and mucin deposition. And we can also see here an occlusive thrombotic microangiopathy. And these endothelial cell injuries are driven by the complement and interferon, and that leads to endothelial cell detachment and exposure of type 4 collagen, leading to activation of the coagulation pathway and hence occlusive thrombotic microangiopathy. This microangiopathy affects both the venules and arterioles. So when we compared the new lesions to the older ones, we observe that the later stage lesions exhibit vessels with reduplicated basement membrane zones that are devoid of endothelium and ultimately disappear due to the ischemia-driven fibrosis. The next point is about the blood interferon gene score is elevated in atrophic papulosis. In fact, there are no data in benign atrophic papulosis. In malignant atrophic papulosis, there are 3 reports. The first is these amazing works by Cynthia Magro in 2011, describing the key role of complement and interferon in Degos disease, and they report a high level of the blood interferon gene score in one patient, similar that observed in lupus. The second report is the one of the case I talked earlier in the presentation. The signature was more than 100, and the last report is this young girl, 9 years old, with a baseline signature about 60. When we focused of the meaning of this lymphocytic infiltrate in the skin, there are two works to consider. The first is this one. They show that this lymphocytic infiltrate is made of T cell, and the co-staining of interferon with CD3 demonstrated that the CD3 T cells are also positive for interferon, suggesting that the increased expression of type 1 interferon in skin is at least partially derived from the T cells. The second work is this oral communication in 2024. They presents preliminary findings from single-cell transcriptome profiling in malignant atrophic papulosis, focusing on blood and skin sample. And they show three things. The first, keratinocytes and endothelial cells exhibited type 1 and type 2 interferon signatures driven by the T cell. Second point, the skin infiltrating CD8 T cells displayed activated JAK-STAT pathway. And finally, the TCR sequencing revealed oligoclonal expansion of the CD8 T cells. There are some identified promoting factors such as genetic predisposition, infectious trigger, and sometimes patients have an overlapping with autoimmune disease such as systemic lupus, dermatomyositis, and systemic sclerosis. So maybe the pathogenesis is that chronic interferonopathy acting on the contributing to the injure the endothelial cells, to stimulate the epithelium, the fibroblasts, leading to the macroangiopathy, to the mucin deposition, and to increase the soluble factors of complement. But it's not enough to activate the complement. And there are a second hit: viral infection, autoimmunity, genetic predisposition to activate the complement and contribute to the formation of the membranous attack complex. So this being said, which drugs should be considered for the management of malignant atrophic papulosis in France? This diagram, taken from the reviews of Roberts and Hott in 2023, summarizes the main players identified in Degos disease. Just be aware that treatment of Degos disease is based only on empirical data. And there are, in fact, no trials, so all of this treatment are given off-label. So possible targets include platelet aggregation, complement pathways, interferon signaling, JAK-STAT pathways. Kim and all in 2021 provide valuable insight about how to treat malignant atrophic. And in fact, we have to consider combined therapy. When we use monotherapy, low dose of aspirin is not enough. Steroids is ineffective. Eculizumab is not enough. So when we combine aspirin and eculizumab, so there are some clinical cases reporting very promising results, but so only on severe GIT, but it's not always effective in the management of severe GIT. Sometimes it does not prevent GIT relapse, and it's not effective to treat brain, eye, and cardiac involvement. When we look on the histological findings, there are this paper comparing the result before eculizumab and after eculizumab. So this is a sample from the GIT, and we can see that post-eculizumab biopsies did not show active luminal thrombosis, but only chronic sequela. And we can see that eculizumab partially reverses the complement deposition. When we look at the skin, there was little effect on the occlusive fibrointimal macroangiopathy, and no effect on the expression of MXA and on the mucin deposition when patients are treated by eculizumab. So how to prevent relapse, how to treat patients without GIT involvement. So at this time, prostacyclin analogs have been reported effective, but it's just in a few cases, and it was before the era of treatment targeting interferon. So when we about targeting interferon pathway, there are two reports. The first is in a young girl with brain and skin involvement, initially treated by baricitinib with improvement, but it was not enough, and they had anifrolumab, and they noticed a very dramatic effect. And the second case is the patient I talked earlier in this presentation with eye, brain, and GIT severe involvement. And we treated him by a combination of high dose of anifrolumab, ruxolitinib, eculizumab, and a low dose of aspirin. And we observed a very dramatic improvement. It's the baseline, B is 4-5 months after starting therapy, and C is 9 months later. So what does this mean in practice? So let's consider the case of a beginning atrophic papulosis, that means without clinical signs of malignant atrophic papulosis. So now that the median time from disease onset to systemic symptoms is less than 1 year, but it's a median, and this can extend to 20 years. The situation 2 is the case of atrophic papulosis with gastrointestinal symptoms such as abdominal pain, nausea, diarrhea, or weight loss. In this case, we have to immediately explore the patient, and the gold standard is laparoscopy. If lesions are detected, they need immediate medication. And if your patient has an acute abdomen, of course, surgery is mandatory, and immediate treatment is required. This immediate upfront therapy in France could be the combination of anifrolumab, ruxolitinib of baricitinib, eculizumab, and low dose of aspirin. But we have to remain aware of the need to reduce this immunosuppression as soon as possible, and maybe using the blood interferon score signature monitoring. Finally, the last situation is a patient with malignant atrophic papulosis without GIT involvement. So eculizumab seems to be ineffective to treat or to prevent the relapse. So we have to consider combined therapy with an association between JAK inhibitors and anifrolumab. Just be aware that they are the first clinical trial in Degos disease has opened just since a few days, assessing baricitinib in add-on of the backbone therapy to treat central nervous system involvement in Degos disease. So ultimately, Degos disease is a disease where there is little certainty, but fortunately, there are networks to help us to identify and manage the patient. So please feel free to contact FIMARAD, FAI²R networks. The Degos Disease Foundation in US also organize international meeting every 3 to 4 months where we can share experience about this disease. And to conclude, this is an invitation. Everyone is welcome to the first virtual workshop on Degos disease in January 2026. So there will be a lot of experts from the Degos Disease Foundation and in Germany. So I look forward to be there with you.